Beautiful. Good afternoon, everyone. We'll get started. Thank you, everyone, for joining us today on our webinar on navigating fertility and menopause during and after treatment. My name is Kim, one of the lymphoma care nurses, and I'll be your host for today's session. We also have Nicole here with us. She's one of our other lymphoma care nurses, and she'll be assisting with our questions that may pop up throughout the Q&A during and after the session. I'd like to thank Dr. Genia Rozen, Aisling Murphy, and Professor Kate Stern, who will be kindly presenting for our webinar today. So before we dive in, I just have a few housekeeping items to mention. So we encourage everyone's participation in today's session. So if you do have any questions, please put them into the Q&A function at the bottom of the screen, as the chat function will not be monitored and we'll have the Q&A at the end of the presentations. If you miss anything or would like to re-watch the session, it is being recorded and will be uploaded to our website. This link will also be emailed to everyone once the recording is available. And if you have any technical issues during the webinar, please email nurse@lymphoma.org.au and we'll try to address this for you. So firstly, let's introduce our presenters for this afternoon. So first we'll have Dr. Genia Rozen, who is a Melbourne-trained gynecologist and fertility specialist with a strong focus on medical fertility preservation. She's the Deputy Director of the Fertility Preservation Service at the Royal Women's Hospital and a clinical lecturer in obstetrics and gynecology at the University of Melbourne. Genia completed her PhD researching endometrial receptivity and the uterine effects of cancer treatment. Next, we'll hear from Aisling Murphy. She is an Irish-trained midwife and fertility nurse with a special interest in fertility preservation and women's health. She's the clinical midwife consultant and program coordinator of the Royal Women's Hospital National Paediatric and Adolescent Fertility Preservation Program. Previously, she served as the Fertility Preservation Clinical Midwife Consultant for Reproductive Services at the Royal Women's Hospital, overseeing the National Ovarian and Testicular Cryopreservation Service. And finally, we'll hear from Professor Kate Stern, who is a fertility specialist, gynecologist, and reproductive endocrinologist. She is Head of Reproductive Services at the Royal Women's Hospital in Melbourne, where she leads Australia's first fully public fertility and IVF service. Kate is also Clinical Director and Head of Clinical Research at Melbourne IVF and co-chaired the COSA Fertility Preservation Guidance Committee. She was also awarded the Order of Australia in 2022 for her significant contributions for reproductive medicine. So we'll now get started and I will hand over to Genia, and thank you everyone.
Thank you to everyone who's been able to join today. It's really great to have been invited, and I thank Lymphoma Australia for giving us this opportunity to share fertility preservation information with you, because it's something that we feel is so important, something we're so passionate about, and it's, we believe that education is such a key to to making this program that we have at the Women's even bigger and better. So the topic of my presentation today is fertility preservation before lymphoma treatment. And we'll be talking briefly about the risks to fertility that this cancer diagnosis presents. We'll be talking about fertility preserving options for both females and males, and a little bit about pregnancy after treatment. I have no specific conflicts of interest to declare in relation to this presentation. So a brief introduction to why fertility matters. Why do we think this is so important, and are so happy that we are able to share this education with you? Well, number one is that thankfully there's been improved survival, and it's actually continuing to improve for most cancers. And that means that there's more people that are actually affected by some of the downstream effects of cancer treatment, and one of those is infertility. And the main opportunity that fertility preservation represents is actually before treatment commences, and therefore early conversations make a big difference. And there's still lots of room for improvement in terms of the usage of fertility preserving strategies, which is why it's so important for us to talk to you today about this. So what is fertility preservation? We sort of throw the term around a lot. It's an umbrella term that's used for treatment to minimize the impact of cancer treatment on future fertility. It's the ability to preserve and provide hope for patients who want to have a family later in life. And of course, that's not everyone, but we know that it is an important aspect of survival from cancer, that people want to be able to have a family just like their peers. And we know that cancer-related infertility affects at least 1 in 10 patients of reproductive age who have survived cancer. And in some cases, from some cancers, that's a lot more common. Other aspects of reproductive care that we also shouldn't ignore, but doesn't directly come under this heading, under this umbrella term, is the management of complex contraception needs that can occur after lymphoma treatment, hormonal management, management of things like sexual dysfunction, and also psychological issues. So the risk of infertility in patients with lymphoma relate to the number one, decrease in the number of follicles that produce eggs, as well as reduction in sperm numbers or sperm production. And one of the ways that that I think is sort of makes it very clear for females about what happens after chemotherapy is that we all are born with as many eggs as we're ever going to have. We lose them throughout our reproductive lifespan, and we're all following our individual curves that you can, for example, imagine there in that graph. And what chemotherapy does is reduce that number so that someone would follow a curve that is lower than they otherwise would have had, and that usually would reduce that window of opportunity where they have eggs that can be used to create a pregnancy. So the person's starting baseline of their ovarian reserve is really important there. Another way we can picture it is a 20-year-old's ovary that is full of those follicles that we can see in the left pathology slide. So in that middle there, we can see lots of follicles. They're surrounded by sort of a white halo. In a 40-year-old's ovary, we're hard-pressed to find 1 or 2 follicles, and that's how that follicle loss is represented. It also, the cancer treatment may also interfere with the functioning of other reproductive organs, like the uterus. It may also damage the signalling pathways between the brain and the gonads, so the ovaries and testes. And there are lots of things that actually affect the risk to fertility. So it's not always possible. In fact, it's usually very difficult to be able to predict what the infertility risk will be to a person when they're first diagnosed, or even once the treatment that they're going to have is known, because it depends on things like age of diagnosis, baseline ovarian reserve, the type and dose, as well as the combination of chemotherapy drugs. If there's radiation involved, the location and dosage of the radiation, and other things like stem cell transplantation, whether that's required. Now, there's data to sort of suggest whether someone might be at a very low, intermediate, or high risk of infertility according to their treatment. But other things, there's lots of individual variation even within that, but other newer agents like immunotherapies, for example, which also may have effects on the ovaries, on the testes, and a lot of those things we only really can suspect from animal studies, from animal models, because they're newer agents and we just don't know yet their full effects. But what we do know, and this has been the case for many years now, is that cancer survivors are far less likely to be able to achieve pregnancy after their diagnosis and their treatment compared to the control population. And that means compared to the general population who weren't diagnosed with cancer. And if we're looking specifically at lymphomas, we can see that that is the case, the blue line representing those who didn't have cancer and their chances of achieving pregnancy, the red line being lower, therefore less probability, less chance of being able to have a pregnancy afterwards. And this is why we think it's important to have these conversations and to have them early, so that we can kind of try to get that red line as close as possible to the blue line. So what are the options that we think about in 2025? Thankfully, there's been lots of improvements in technology. Ovarian stimulation for women to freeze mature eggs is a really, really successful strategy these days. Ovarian tissue is another option, even for adult or post-pubertal women, and GnRH analogues, which are injections that essentially put the ovaries to sleep during the duration of the chemotherapy. For girls or prepubertal girls, so before the onset of puberty, ovarian tissue is the only option for fertility preservation. For post-pubertal boys or men or adult men, mature sperm freezing is a very successful option, because we only at the very end, if a man was to need to use that sperm, would need to inject a single sperm into the egg in order to create, or into multiple eggs, in order to create embryos, which are then able to be used for pregnancy. However, for prepubertal boys, testicular tissue freezing is currently the only option. And in fact, at the moment, it still is experimental. So egg freezing has been around actually for quite some time. The first baby born following egg freezing was in 1999, but it wasn't until 10 or 15 years later when the technology really improved with something called vitrification, or snap freezing of eggs, which made the outcomes a lot more successful in terms of the eggs surviving the thaw and being able to create subsequently pregnancies. In the group of our medical population of those women who had cancer and came back to use their eggs, approximately 1 in 10 women so far from the data that we have were coming back to use these eggs. But as egg freezing becomes more and more common, we think potentially this number will increase as well. So I wanted to talk a bit about the actual process of egg freezing, because it's something that for our patients who are doing it, for example, either electively because of getting older or for other reasons, there's lots of time to go through the ins and outs. Whereas with our patients who've just had a cancer diagnosis, often things are very rushed and there's not a lot of time to really to be able to explain it, or for them to have that sort of time to digest the information. And one of the things that has made, in fact, this the egg freezing process a lot simpler and a lot more possible for more of our patients, even with lymphoma, is the ability to start this stimulation or the injections at a random part in the cycle. So there is no specific timing like in the past where it was with the beginning of a cycle, with the onset of the period that the injections would start, but it really can be at any point in the cycle, because we're trying to get a cohort of follicles to grow. And we know that that cohort, that group of follicles, can be recruited at different points in the cycle. So the follicle stimulating hormone is the main injection for this part of the cycle, and that's the injection that's used to get multiple follicles to grow, as opposed to naturally with only one follicle growing and that one follicle ovulating the egg. With this, we're able to get a number of follicles growing and hopefully quite a few eggs from the stimulation. The other part that's different for patients in this group is that we sometimes have enough time to actually do this twice. So the injections go for about a week and a half, roughly 10 days, then the egg collection occurs, and then we can actually continue the stimulation again to do another egg collection after another 1.5 or 2 weeks. And that allows us to be able to bank more eggs, which gives an even higher chance, or more realistic chance, if we didn't get many eggs the first time, in order to have a pregnancy in the future. So the ultrasound monitoring is something that we do to check to see how the follicles are growing. So that happens in that sort of 1 to 2 week period. And the number of follicles that grow and the number of eggs that we get in our patients, for example, with lymphoma, seem to be very, very similar to what we would get with someone who doesn't have cancer, which is a really reassuring thing. At the end of that 1 to 2 week period, something called the trigger injection that allows us to then, 36 hours later roughly, collect the eggs. And the egg collection itself is one of the big parts of this process. It's done with the patient asleep or like a light sedation. It's done under ultrasound guidance, so very similarly to how we do the ultrasounds, but there's also a needle on the end of the probe, which we insert inside of those follicles, drain the fluid, and our scientist is able to isolate the eggs from that fluid, and then the mature eggs are frozen. So this is where the process ends for most of our patients. The eggs are frozen in time and they don't deteriorate in quality. So even when someone is coming back 10, even theoretically 15 years later, there's no deterioration in the egg quality. So what happens when women come back to use the eggs? Reassuringly, the live birth per embryo transfer, so when we're using those eggs to create an embryo and we then transfer the embryo inside the uterus, the live birth rate looks to be very similar to those who did not have cancer. And that's really, really important. So that was an important finding from a study a few years ago. And about 10 or 15 eggs in those women who are under 35 when they froze eggs were needed to achieve a birth rate with all those eggs of about up to 70+%. So sometimes we get in excess of 15 eggs, 20, 25 eggs. So we're able to get pretty good success rates with the frozen eggs. But of course, not everyone that freezes eggs is able to have a baby from that. So that's an important limitation to be aware of. So sometimes we see patients who've been diagnosed with lymphoma who actually have already been trying for a family when this occurred, or they were ready to start trying and they have a partner. And sometimes in those situations, we actually will freeze either either embryos instead of eggs, or eggs as well as embryos. And there are pros and cons of both. So for example, eggs have the advantages of belonging to the woman, and therefore if a relationship was to break up, she would still have the benefit of those eggs, whereas embryos would not be useful for either of them. The other thing is that eggs can always be, made into embryos later on, whereas embryos can't be unmade back into eggs. So especially when those embryos are not needed in the future, decisions can be easier about discarding them, etc., if they're eggs rather than the embryos. But with embryos, we do have a little bit more understanding of the chances of success for the future. So it does give us a bit more information. And also there is a very small advantage of not losing the roughly 1 in 10 eggs when they're thawed. So there's a tiny bit higher chance of success. But a lot of patients still think that they need to freeze embryos, that embryos work much better. But thankfully that isn't the case because eggs have become much more successful. So if we are going to go down the path of freezing eggs, then the next part, actually, the fertilization of the egg happens inside the laboratory, so it doesn't change the timing of when the woman's able to start chemotherapy. And if we're freezing embryos, and that happens on day 5 or 6 after the eggs have been collected, when these embryos called blastocysts are created. So most studies don't show decreased implantation and live birth when compared to healthy controls. And we're reassured that even those that do, in general, show very, very similar outcomes. But what about pregnancy complications? Well, thankfully, there appears to be no increase in congenital abnormalities or birth defects. There is a slightly higher risk of complications such as high blood pressure or gestational diabetes and preterm birth. But overall, the data is really, really reassuring. And other things that there's no excess risk of are things like genetic disorders or chromosomal issues. So again, we can reassure our patients that if they do conceive, whether it's with, naturally or with the help of IVF, that the outcomes are really, really, really reassuring and good. So the next option we have is ovarian tissue cryopreservation. It's no longer considered to be experimental, and it's endorsed by some of the peak bodies in this area. It's especially the treatment that we would do. It's the only option, as we said before, for our prepubertal patients, but also for those where immediate treatment is required or when chemotherapy has already started. So with the ovarian tissue cryopreservation, we can see on that left side, we take a part of the ovary, it's cut up into strips and then frozen, and then separated in time in the future, years and years later, when there's confirmation that there is no ovarian function, the ovaries are no longer working, that they've run out of eggs, we're able to use that tissue by grafting it back inside of the body and then using some mild stimulation in order to get eggs from that tissue. So we can see here the few different locations where the strips of the ovary can be inserted into, back inside the pelvis under that silky smooth sort of lining, what's called the peritoneum. And we're able to see on this ultrasound picture the follicle that grows. This one's in the abdominal wall under the skin, and we can see a picture of that at the time of the keyhole surgery, that bulging follicle that can be aspirated to retrieve an egg from that fluid. In our experience with over 60 patients who've had tissue grafted, the chance of pregnancy is about 20% per embryo transferred, which is a bit lower than with IVF in the general population when we're talking about getting lots of eggs at once from the ovary, but still really, really high. And we have, Aisling will speak to this a lot more, but one of the things about ovarian tissue is that it's a very different process for actually slicing up the tissue and freezing it requires a lot of expertise that isn't available in general IVF units, and therefore one of the limitations of being able to offer this service is that often patients don't live near places that can do this. So in 2019, we first established the transport and cryopreservation service with the generous help of Sony Foundation. And now we've sort of got the 2.0 version with another very, very generous grant from the Children's Cancer Foundation and My Room. And we're able to continue to provide the service and in fact expand it all over Australia to be able to transport tissue to us at the Royal Women's Hospital for processing and storage. And ultimately, we can then do grafting either here at the Women's, or we can even transport tissue back to the original centre. So quick word about the GnRH analogues. That's the injections that are putting the ovaries to sleep. They sort of provide some protection of ovarian reserve, and we tend to use them when there is chemotherapy that is gonatotoxic, but it is only able to really protect some of the ovarian reserve, and those with a low starting point is probably just not quite enough to prevent premature menopause. So we try not to make that the only option because it doesn't necessarily give us the result that we want, but it's often combined with other fertility preserving options. And just in the interest of time, so we'll go through the male effect. So chemotherapy and especially radiotherapy on the testes can cause scar tissue development. The normal cell lines are sort of destroyed by the cancer treatment, and in some cases when there's, again, a very toxic, particularly toxic treatment, can cause the whole testes to be replaced by scar tissue. And there are some agents that do that much more than others. There's also, apart from impairing sperm production, of course, there's also the hormonal function, the testosterone producing cells, which are affected as well. And so for males, the issue then also becomes of testosterone replacement, in addition to the issues around not producing sperm. And in fact, we know that sometimes the sperm quality can even be impaired before starting those toxic treatments, especially for conditions that are sort of widespread throughout the body, like leukemias, for example. So for post-pubertal adult males, the gold standard is to freeze sperm, and that's an extremely successful option. And sometimes there's some extra things that are needed to be able to do that, but in general, we are able to get sperm and to be able to freeze it. And the outcomes, the pregnancy outcomes, are very similar, again, to what I've shared in women compared to non-cancer controls. For prepubertal boys, we've got the testicular tissue cryopreservation option. It's for boys at high risk of fertility loss. It's applied as part of an ethically approved research or protocol. And we hope that in the very nearest of futures, we'll be able to use the mature sperm will be able to be retrieved from that tissue after it's been grafted back, in order for that sperm to be used to create embryos, which then can create a pregnancy. There are, of course, other options. And, I always say that even if plan A or B don't work out, there are other things that can be done in the future, such as donor eggs, donor sperm, or even donor embryos. Sometimes surrogacy can be used. So for those that do maintain and want to have a baby, there are other ways to be able to do that as well. So fertility, we know, is a key issue for survivors of cancer, and there is acceptance that fertility preservation should be a part of cancer management. We really recommend avoiding delays to getting the education, the effective fertility preserving options offered, and we have support and resources available. For example, our program, which we'll speak to you more about. And I'd like to thank the whole team for their massive efforts. So we're going to do questions at the end, but I'd like to now introduce Aisling, our clinical nurse. Just stop sharing one sec. So clinical fertility preservation nurse. She heads our in-time program, and she'll be speaking to you about the logistics of our program at the Women's. Thank you, Aisling.
Thank you so much, Genia. Hi, everyone. Thank you so much for taking the time to be with us today on this sunny Thursday afternoon and evening. So I'm just going to share my screen at the moment. And like Genia said, we will be taking some questions at the end. And I will also be sharing our contact details at the end, that if anyone has a question that they didn't get around to sharing within the webinar, that we are available for any questions or queries that you may have as well. So today, I will be talking about accessing fertility preservation services, not only here within Victoria, but also nationwide, and the available kind of clinics and people that are out there that you can speak with, how to get a referral, regardless of kind of where you are in Australia, and just the importance of having the conversation, no matter kind of where you are in your point of treatment, before, during, after. If you're a parent or a caregiver, sister, brother, mother, aunt, uncle, there are always options out there available. So let me just see. Here we go. So yeah, just echoing off of what Genia said, you know, the importance of having the conversation within this oncofertility space, regardless of diagnosis, but I suppose lymphoma specifically today. There are so many options out there, but there are, I suppose, kind of gaps and noticeable gaps, pending, you know, clinician knowledge, oncology knowledge of kind of what is out there and what is available. Nationally, it would be gold standard of care to have the conversation of fertility preservation prior to the commencement of any treatment. But also, it's just good practice as well to kind of continue mentioning, I suppose, the options that are available post-treatment and then into the kind of survivorship area. There are so many options out there. It's a real kind of hot topic at the moment, and it's so important, I suppose, to kind of take ownership of this kind of period of your life now. But echoing from what Genia has said, you know, acting early can give you more choices. And at the end as well, I'll be sharing many resources as well that are available just for independent learning and getting as much information out there as possible. So as I said, the window of time, obviously best time to preserve your fertility and your future fertility would be prior to your treatment, but that is not to say that there aren't kind of options out there during your treatment as well as afterwards. And afterwards, Dr. Kate Stern will be kind of discussing how to manage some kind of fertility symptoms that you may be experiencing post your treatment, but also the other options out there available for your future fertility and your future family. So during treatment, most of fertility preservation is discussed prior to the commencement of your treatment. But it's important to mention that not only are there clinical options available to kind of preserve your fertility, it's also just so important to touch on the psychosocial aspects of it as well, of how this will now impact your life going forward, and kind of what you might have viewed as kind of the path that you'd be on has now changed. So the supportive different support areas that are available, not only kind of clinically, but also psychosocially as well. So some hormone protection is available, like Genia said, the GnRH agonist, so the Zoladex treatment throughout your chemotherapy, and as well sperm banking between chemotherapy cycles. There's evolving kind of research in there. So I suppose now we'll just be moving on to how to have that conversation. So after treatment as well, so important to discuss the family building options that exist, not only biologically, but also the other available options that are out there now, like Genia was saying, with surrogacy, donor options, adoption, and keeping on top, I suppose, of how you're progressing post-treatment as well. So how to access services in each state. So majority of the time, referrals would come from treating oncologists at the point of diagnosis, but that is not to say that there are other alternative ways to get a referral to fertility preservation or fertility services. So primarily it would be your oncologist, and that could be at any point during your diagnosis and your treatment, but also equally if you're kind of years down the track and you potentially had lymphoma as a child and now you're here, you can get a referral through your GP. And that could either be to a publicly funded fertility service, or equally, you know, a private clinics that are available. So first and foremost is just to have the conversation of what you're potentially struggling with, maybe post-treatment. If it is prior to the commencement of any chemotherapy or oncology treatment, then there are urgent appointments available in fertility clinics around Australia. When a referral comes in and it is marked as urgent, it's triaged, I suppose, just that. The process is very quick. It's not like kind of any other appointment where you would be seen within 7 to 10 days. Usually, most clinics would have the availability to see you same day, if not within 24 hours of receiving the of receiving the referral. So because we are aware that time is so critical, and first and foremost, I suppose at the point of diagnosis, your journey is kind of set then on getting well and commencing your treatment. So we're so very aware of kind of how critical the timeline is, and we act very, very quickly once the urgent referral has come through. And as well, the other thing that is important to mention is the funding option. So I'll be touching base on a few of those now. So within Victoria, which is where the Royal Women's Hospital is based, over in Parkville, we have launched public fertility care. It was launched in July 2023. It is funded by the Victorian government, and referrals or access can be sent through either a GP or a specialist referral from an oncologist, from support services available, or even just word of mouth. You can self-refer, I suppose, to your GP and then get them to give us a call or fill out our referral form. All of our information is available on our website as well. So we offer free or low-cost services for IVF, IUI, and ICSI. We have a very comprehensive fertility preservation program for pre and post-oncology and non-oncology patients. We offer genetic counselling, testing, and donor support. And recently then we have launched our public egg and sperm bank for any potential donor recipients or donors coming through Victoria. So within Queensland then, Queensland have made massive progression to their assisted reproductive technologies. There has been a huge investment into this area, $42 million put into assisted reproductive technologies across the state. One of those being their statewide fertility preservation program. And if anyone is here within Queensland and has questions about that statewide FPS program, they're more than welcome to email me at the end. We would be in very close contact, I suppose, with certain areas, certain clinics around Australia, and I can pass on details of how to refer and the contact details to get in touch to see if you would be eligible for their service. Within New South Wales, there are rebates and supported clinics available, both through private IVF clinics, but also low-cost models based in the Royal Hospital for Women, the Royal Prince Alfred, and Westmead. Speaking on that, the Royal Hospital for Women have like us, very comprehensive fertility preservation program. And just like in Queensland, if anyone is from New South Wales, I do have the contact details for that program. So feel free to email me. Within South Australia and Tasmania, ACT and Northern Territory, there are limited or no publicly funded fertility services currently. I do know that within ACT, pending an oncology diagnosis, you may get your treatment through New South Wales. So you could access fertility preservation services through there. But like we said at the beginning, it's always encouraged to speak with your GP or your specialised gynecologist, andrologist, or your primary treating team to start the conversation, no matter where you are within your diagnosis. Which then leads us on to our national programs. So around Australia, as Genia was saying, we launched our National Ovarian and Testicular Tissue Cryopreservation Service in 2019. And that was the Royal Women's Hospital Fertility Preservation Service, I suppose, looking at the gaps of how to access fertility preservation services and the options that are available to primarily the metropolitan areas, and seeing how we could advance more referrals coming through, more access, more patient advocacy for their future fertility. So with that, the NOX program was launched with the very generous support of the Sony Foundation. So it's a national initiative, and we offer free ovarian testicular tissue transportation and cryopreservation. Funding is supported through the Sony Foundation. So this would mean then that the procedures are done locally, so within your referring state, whether that be at a fertility clinic or a primary hospital. We would organize the transportation, but you would have your surgery or your operation done locally, and then the tissue then would be brought down here to Melbourne. So this is it's an amazing initiative, and it's an amazing program out there for patients who don't necessarily have the time to proceed with egg freezing or embryo freezing. Like Genia was saying, it's so amazing that you can start at any point during your cycle, but there is ultimately that kind of 10 to 16 day window that you would need to complete the cycle. And with that, there are fertility clinics across Australia who are very comprehensive at ovarian and testicular tissue freezing. But here at the Women's, it's our bread and butter, and we have been doing it, for a long time, and we have great success with grafting that tissue back. And there's research now being done within the testicular tissue space. So this is a great, I suppose, plan B if you are at that early, quick stage of your diagnosis where you wouldn't necessarily have a lot of time. So with that, we launched in 2019. So this is just a breakdown of some data from 2019 to 2024. We have received almost 150 referrals to date, with 22 inquiries coming from the UCAN or the Sony Foundation website. So that box is available, it's live. We get sent an email notification of any query that comes through, and we reply very, very quickly with that. So please feel free to visit the website as well, should you have any questions, to see if you are eligible for this program. And that's just a breakdown then of the referrals that we've gotten through from each state. So depending on where you are, you can see the percentage breakdown of referrals that have come through. So with the Knox program, we were able to kind of break down the data and the patient accessibility, and see kind of where the gaps were within oncofertility care. And with that, our new fertility preservation program In Time was launched. So with the very generous support from Children's Cancer Foundation and My Room, we were able to launch this very important program. So our vision is to give children and young people with cancer the opportunity to start a family later in life, regardless of where they live in Australia. I suppose that space in that prepubertal or that before puberty stage of your life, there is ever developing research out there to see kind of what the options are for young children and adolescents before they reach that point that they're able to do an egg freeze or a sperm freeze or an embryo freeze, and that there are still options available for these young children and adolescents. So with our service, we coordinate and we fund the transportation of tissue to the Royal Women's, exactly like our Knox program. We freeze the tissue here on site, and we're also available for advisory support and consultation for health professionals, but also patients themselves. And all of that is of no cost to the patients. To yourself. So for eligibility then for this program, you need to be between the ages of 0 and 24, so 24 and 11 months. Medicare eligible, only patients diagnosed with cancer. So that includes young people who have been previously treated for cancer on a case-by-case basis. Important to mention that if you were a non-oncology patient, there are still options out there for you. And like I said, our email is at the end of this presentation, and you can be anywhere in Australia as well. The exclusions for this In Time program then would be the transportation of any gametes, so of eggs, sperm or embryos, patients who do not have cancer, and non-Medicare patients as well. So how to refer to us: here is our email address and our phone number. You can either send us an inquiry to our email or leave us a voicemail or give us a call on our number. But if you, from these few slides, know that you are eligible for these programs or know anyone, you can send a referral to the Women's. Our referral form is on our website, or you could get your GP to fill it out. And the transportation of this tissue would be covered, the storage, and all future options then will be discussed with you with one of our fertility specialists. So for other storage funding programs that are out there, recently a national funding program was launched. Here's the QR code if you are able to scan it. So this funding program has been launched, I suppose, to aid the financial support and the financial kind of burden of those who have frozen eggs, embryos, or sperm throughout their years of diagnosis and treatment. To access this funding, you do need to apply for it yourself. So once you scan the QR code and you're on the website, there's a form that you need to fill. The eligibility criteria is up there as well, but I suppose to touch on it, you need to be a Medicare holder, and only patients with or have a history of cancer or who required to medically freeze eggs, embryos, or sperm for genetic purposes as well. And they would fully fund the storage of eggs, sperm, and embryos for up to 10 years. Resources then, there are so many out there. Sorry, I'm just conscious of time. There are so many out there. Like we said, the assisted ART storage funding program. There are many, many resources out there available on our women's website, but also through third-party organizations such as Canteen and Future Fertility. So the essential points and the takeaways from this then would just be to talk as early as you possibly could about your fertility. But if you have any questions at any time, there are fertility specialists out there, GPs, your primary treating team. Support is available emotionally and financially. And your future family is worth having the conversation. So thank you very much. I'd just like to introduce Associate Professor Kate Stern. So she is our leading reproductive fertility specialist here within the Royal Women's Hospital in Victoria. She's internationally recognised for her expertise in oncofertility, fertility preservation, and reproductive medicine. She's the head of our FPS service here at the Royal Women's and has been instrumental in pioneering national programmes for all ages and diagnosis. So thank you so much. I'll just stop sharing my screen. There we go.
Thank you so much. First of all, thank you so much for having us today. It's so important that we can you see my slideshow? It's so important that we have this opportunity to engage with our patients and our healthcare professionals to talk about fertility after lymphoma. And as Genia and Aisling have explained to you, there are lots of options and everybody needs to be able to have a chat. And I'd really just love to thank the Lymphoma Foundation, Kimberly and Nicole and the team for making this happen today and for really doing everything they can to expand the awareness and education for our patients. Actually, Genia and Aisling have really covered quite a lot, so I'm just going to talk particularly about fertility after lymphoma. So we do have funding from Melbourne IVF, from the Sony Foundation, Merck Serono and Ferring, and more recently, as Aisling has alluded to, the Children's Cancer Foundation in my room, which is very, very exciting, and the Moyna Fox Trust. We have no financial or commercial interest particularly for this. So one of the burning clinical questions in oncofertility is how can we help our patients after they've survived their disease have their own family? I'm going to talk about women first. So after the cancer treatment is completed, there are several things that we need to be thinking about. Regular assessment of hormone function, hormone replacement as appropriate, sexual counselling, and I'm not specifically talking about this today, but it really is a very, very important area. and either future or first fertility preservation options, and when for patients to start trying to conceive. So just to recap a little bit from Genia, when a patient has chemotherapy, usually the ovarian function will stop temporarily as a result of that chemotherapy. And we call that temporary ovarian insufficiency, and that often recovers. If the ovarian function never recovers from that point, then it's called permanent ovarian insufficiency. And the common pattern is that with the chemotherapy medications are toxic to the ovaries, so the periods will stop. And then they will come back for some time afterwards, but then patients are still at risk of losing their ovarian function earlier than they would have otherwise. So it is reassuring when the cycles come back, but that doesn't mean they're going to stay there for a long time. So very important to understand that. Now, AMH is a test that you might have heard about, anti-Mullerian hormone. People think it tells you how many eggs you have and how many good eggs, but it's really a very vague indicator of the eggs that are left, not an absolute indicator. And importantly, it doesn't tell us about ovarian function, it doesn't tell us about when you're going to have your menopause, and it doesn't tell us actually about egg health. It's a blood test that we do to assess whether we've had restoration of function and some eggs hanging around ready to be able to be retrieved. We test patients before their treatment because it'll give us some idea for later on, and we test it later. Sorry, I just had a hand up coming. So we then tend to retest 1 to 2 years after a patient has finished their lymphoma treatment. So this is a bit of a graphical representation. If you look at the first jar, I always think about the eggs as like looking like freckles. And before you start your treatment, the jar's full. And then after you finish your treatment, usually, but not always, there are still quite a lot of eggs left. And that's good, but it's not as many as we would have expected. And then what happens is you run out of eggs early on, earlier than would be expected. So when we're seeing patients to talk about post-treatment fertility, there are some considerations we need to evaluate to help our patients work out what to do. First of all, we're interested in the age of the patient. We're interested in what her ovarian reserve is looking like after treatment, and also what her egg function is looking like. And that's not just AMH. We're also looking at the toxicity of the cancer treatment that the patient's had. And we're looking at a pattern of what's happened to her ovarian function after the treatment. So, as I was saying before, and this is a bit of a complex graph, but basically what it's showing you, and I'm not sure if you can see my pointer, is that if you look at ovarian function before chemotherapy, we then look at how it recovers afterwards. So when a patient has had a stem cell graft, that's the black line down here, you can see that the ovarian function may recover just a little bit later on. In fact, the more recent data, this was produced in 2021, and it's likely actually with the more modern regimens that we would say that 20% to 30% of our patients, depending on their age at the time of treatment, would actually recover their function after autograft. BIACOP is another common treatment, and that has a reasonable impact on the ovary, as we have seen with Genia's initial slide. But we expect about 40 to 50% of good recovery. And then CHOP and treatments like that are about the same, and ABVD tends to recover a bit earlier and a bit more. But as a rule of thumb, ovarian reserve is going to get better over the next couple of years. So assessing someone's ovarian function at 2 or 6 months after they stop chemo and it's not very good, it still has the potential to get better. So should we consider fertility preservation after treatment? As Genia and Aisling have mentioned, sometimes there's not enough time, sometimes we didn't get a very good result. So it may be possible to obtain further eggs or embryos after treatment as well, but that will really depend on how good the ovarian function is. So as long as there is some ovarian function afterwards, and that might be 12 months or 2 years afterwards, we might actually be able to get some eggs, even if the AMH is still low. And we think about, what does the patient need? What sort of support does the patient already have for her future fertility? If there's not much, if she doesn't have eggs or tissue or not many, then we might be able to get some more. So it's an individualized decision, and it's, you have to assess everything about our patient, and then with the patient, with her doctor, can make some decisions. So when patients want to have a baby, it's very, very important, as Genia said, you need to check everything out with the treating specialists regarding the safety for pregnancy. So you might have to have an echocardiogram of your heart. You may have to have lung function tests and thyroid function tests and breast checks. So that's the first thing you need to do, is make sure your specialists feel that from a late effects point of view, everything's as good as possible. And then the next step is to check out what the fertility is like, because it might be possible to have a baby without any fertility assistance, and that would be fabulous. That's actually everybody's main aim. And then we mustn't forget the partner, or if a patient needs to have sperm donation if she doesn't have a partner. So it's important to make that assessment about what to do, what to think about when you want to have a baby. And as I said, our patient can try themselves if there is reasonable ovarian function. We can try using IVF as long as there's ovarian function, actually, to try and have a baby using fresh eggs, or we could decide to use the frozen eggs and tissue. And Jenny's given you a very comprehensive update about that. And sometimes we have to consider donor options, and I'll talk a little bit about those at the end. So this is, I know this looks a bit busy, but this was a nice study, and it looked at patients who had very, very low ovarian reserve, but they did have cycles and they did have some eggs left, who tried themselves, and half of those patients were able to have a baby themselves. So that's a really, really great outcome. So having a low ovarian reserve doesn't stop you being able to have a baby yourself. It's having more of an impact on the number of eggs if you're doing treatment. Now, Genia's already told you about how useful frozen eggs are, and we're so pleased. This is data, Genia gave you data from a lovely publication from 2021, and this is actually our data in Melbourne from the Women's and Melbourne IVF, which showed that if you've had eggs frozen, regardless of the cause, you have a very good chance of getting pregnant, and it's not particularly different whether you were, related to the reason that you were freezing. So we're very pleased. And as Genia said, our results from egg freezing are really about the same as our fresh results nowadays, which is fantastic. So what about grafting ovarian tissue? As Genia said, ovarian tissue provides an additional opportunity. We need to make sure our patient's healthy. We need to actually do a laparoscopy to put the tissue back, and then we begin tracking cycles. And it often takes many, many cycles to have success, but our pregnancy rate once we get eggs is 21%. Now, what about boys? Our patients, our young men, they want to know when they come back to see us, what's the impact of the lymphoma and its treatment on fertility and recovery? Often we'll see young men who've frozen sperm before they had their treatment, and they're back now and they want to have a baby with their partner. And the first thing we do always is a sperm test to see if there is some sperm. And there often is sperm. There's good recovery. But the young man wants to know, is that sperm safe to have a baby? And the good news is that there is no increased risk of abnormalities in babies born to men when they're using fresh sperm after they've completed their cancer treatment at least 6 months before. And what's interesting is that it takes about 2 years for the sperm to really recover. Genetically, we see improvements at about 18 months, and then in just terms of the sperm concentration, it can take a couple of years. But there's no reason not to use fresh sperm if you have it at that time. Now, another of the burning questions is, and the girls alluded to this, how can you have a family in other ways? Sometimes you haven't been able to freeze eggs or tissue, or you've used them and there's no opportunity, and a patient has developed premature menopause or premature ovarian insufficiency. So nobody's best idea is to have to think about having donor eggs, but at the time, if that's the only option, it's really a very helpful option for our patients. I mean, you have to think about expanding your family. What you're trying to do is have your family. And if you can't have a family with your own eggs, you can still have a family with donor eggs. One of the things that I always find comforting is that when you carry a pregnancy with donor eggs, through your bloodstream and factors within it will influence the DNA in the pregnancy, so that you are still having some influence on the development. It's called epigenetics, on the development of your baby. And I think that's a very comforting thought. Donor egg programs are available in public. The waiting list is very long, and most of the IVF clinics have donor egg waiting lists, which are still quite long. There are other options, including finding your own egg donor, either advertising or somebody that you know. Donor sperm for men who don't have any sperm left is very, very accessible. There are, unfortunately, still at the moment in our public program, the wait list is very long, but around the country, there's very little wait for donor sperm. Sometimes your body is not able to carry a pregnancy. And in that situation, you need to consider surrogacy. And that could be for medical reasons, that it's risky to carry a baby, or complications of treatment. And surrogacy is available. In Victoria, we have very, very active surrogacy programs, and we have an independent government committee that approves surrogacy cases. The hard thing is often finding a surrogate, and usually that's people come to us with a surrogate, somebody that they know. Interestingly, pregnancy rates with surrogacy are very good. And so if you have embryos frozen, but you are unable to carry a pregnancy yourself, then we would expect to have just as good pregnancy rates with surrogacy. So these things are not, nobody really wants to have to resort to this. It's a bit of a double whammy, isn't it, after your cancer treatment? But sometimes when that's the option that's available to you, you just need to run with it and then embrace it. Now, the last thing I quickly want to talk about is managing symptoms after lymphoma treatment. And I'm talking about symptoms of premature ovarian insufficiency. And I just want to highlight this video, which is a great video, and it features a very close colleague of Genia and mine, Professor Richard Anderson, and it's from Lymphoma Action in the UK, and it's really, really fabulous. It's 7 minutes, so I didn't want to show it, but it goes through all the symptoms and how to have treatment options. So the most obvious changes you're likely to feel are in your periods, in that they become less frequent and they might stop. Mood changes are common, particularly low mood, poor sleep, often waking up with hot flushes, sweats with hot flushes. And that's frightening for patients that have had lymphoma and leukemia, because often the first presentation of the lymphoma is sweats. It's hard to say it's a different type of sweat, but it is a different type of sweat. vaginal dryness and uncomfortableness when having intercourse, and lower libido. These are all symptoms of low estrogen associated with ovarian insufficiency. Those symptoms can be temporary, they could be intermittent, or they could be persistent. And as we said, it's, they might feel like lymphoma symptoms, so it is confusing. Always worth trying to sort this out by talking to your doctor. But the most important thing I want to get across is it's important to manage these symptoms. Don't ignore them. A, because they can make you very, very miserable and your quality of life poor. But B, because there are solutions to make you feel much better. So regularly checking in with your team for symptom management is important. If your estrogen is persistently low, it is worth considering hormone replacement therapy, which is also important just for symptom management on its own anyway. We want to try and normalize the hormones and also discuss options for fertility. Now, diet and lifestyle factors are really important. I know everyone trots these out, but they actually make a big difference, as does regular exercise, particularly in terms of your bone strength and bone health. Psychological support is very important. I'm not sure how many of you have heard of this or experienced, but often after you've recovered from your cancer treatment, that's when psychologically it all falls in a heap, 1 to 2 years after you've finished your treatment. And your body sort of had to be so resilient to get everything through the process. And so that's when your body allows yourself, your mind allows you to then sort of address what happened to you. And it's very important. And we recommend all our patients have psychological support. And then there are the medical treatments. So in terms of hormone replacement therapies for young women, that's a whole talk on its own. But basically, we want to restore the physiological environment. So we can have tablets, we can have vaginal creams or pessaries or rings, or we can have transdermal implants and patches and sprays and gels. Usually it's a combination of estrogen and progesterone. HRT or menopausal replacement therapy doses are lower than the pill. They're just trying to give you physiological doses. And so actually this is quite important to remember that it's not contraceptive. So it may be that that the ovarian function resumes, but you may not notice that because you're not having a period. And it's important to know that HRT will not be actually contraceptive, but neither would it stop a pregnancy, which could be a happy thing. These doses are lower than the pill. And there are differing opinions about how much you need. There are some studies that suggest that young women really need higher doses, such as the pill dose. But other studies suggest that just replacing the normal average physiological level is okay. And it's important for symptom control. It's incredibly important for bone health. And survival studies show that women that have hormone replacement therapy have better quality of life and have longer lives than women who don't after early menopause. And I guess I just want to finish by saying, as the other girls have said, help is available. You just have to Google, and there are so many websites, Royal Women's Hospital, Fertility Society of Australia, just Google fertility preservation. The Sony Foundation has great resources, and they actually direct a lot of patients to us. So it's just really important to know that you're not alone. Talk to your fertility provider if you've seen one before. Talk to your oncology nurse navigator and your team. Everybody's here to help, and it's really such an important thing to know that you're not stranded. So I just want to thank everyone in this team, and I also want to thank our supporters. Thanks so much.
Thank you, Kate, Aisling, and Genia. That was fantastic. We'll jump right into our Q&A, and we've had some questions pop through. So our first question is, what are some examples of reasons you might choose not to use the ovary pausing injections? And I'll open this up to either any three of you.
This is a Genia question, her topic.
Is Genia still with us?
She might be having connection issues within the hospital. We just got a notification to say that there might be some cutoff with
Okay.
power.
Oh, okay.
Oh no,
Is she there?
I thought I saw a flicker. Nope.
That's okay. So can I just be clear, Kim? The question was, why would you not use the Zoladex? Is that right?
Yes.
Yes, so Zoladex injections do make you feel a bit grumpy and hot flushy. They have been proven in breast cancer to substantially reduce the risk, and the lymphoma studies show that they do reduce loss of the follicle pool, but there's not as much evidence. Many years ago, they were incredibly expensive and lots of patients couldn't afford them, but now they are freely available. We don't really think that there is a reason not to use them. Jenny, you're back on. Maybe you want to answer.
Can you hear me?
Yeah.
Yeah.
Oh, great. I've just logged in from my phone. So the first part of the question, I suppose, is when would we use them? So it's only before the start of or during the actual chemotherapy or the treatment that's causing toxicity. So it's not something that we would use after treatment has finished. So it's during that time to reduce the ovary being exposed or taking up that toxic medication. And we generally not use it if, for example, in certain circumstances when chemotherapy is going on for 12 months or even 18 months, we don't want to, we're not sure that in terms of the balance of benefit and risk, that it's worthwhile to be on it for so long. That would be one instance. And the other instance would be if there's side effects from the putting the split that we can't kind of make better with a little bit of extra estrogen, for example. So if it's not tolerated, that would be another circumstance. But in general, for everyone else, it is an option. And as I said, it can be used in conjunction with whatever other fertility preserving option has been done as well. Kate, anything to add?
I already added before. I think we've covered it.
Oh, sorry.
Thank you, guys.
Okay.
So our next question is, I was 43 at diagnosis. I asked about egg freezing, was told Medicare only covers this for people with cancer up to age 35. I asked at a private clinic, but they thought chances would be low. Ovarian tissue freezing wasn't brought up by anybody. Is this also dependent on age?
I'm happy to jump in with this one as well. So with these treatments, so if we look at ovarian tissue freezing, it is something that we offer to women who are below the age of 35. And the reason for that, because in terms of quality and quantity of the eggs within that tissue, we want it to be as good as possible. And we don't have any cases in the world for whom it's worked when they're in their 40s. So we're generally, not putting patients at extra risks for a return that usually isn't expected to be that great. That's the reason that it's not offered. So that's the ovarian tissue preservation piece. In terms of the question about egg freezing, it is quite a complex discussion when someone is 43 at the time of diagnosis, because the quality of the eggs remaining in the ovaries at that age makes it also far less likely that those eggs can be useful in the future to create a pregnancy. So we tend not to have very hard and fast rules about it, and I think it's really deserves a very careful discussion. But it does, we don't really want to be doing something that carries risks and also, has a very, very low chance of working in the future. So for that reason, that would probably explain the answer that was given at the time.
Thank you, Genia. Our next question, is there any way to access fertility status post-chemo? Oh, sorry, assess fertility status post-chemo.
Well, I might take that. So yes, that's what we want. We want patients to come back and see us after they finish their chemotherapy, and we would start assessments at about 6 to 12 months. So we do ultrasound, well, we ask for patients' history about what's been going on with their symptoms. We do an ultrasound to have a look at the ovaries, and we do blood tests, and we check for ovarian function and ovarian reserve. And we will do that, say, we might keep doing that every few months after treatment. If we get to 2 or 3 years down the track without anything, with just clear premature ovarian insufficiency, then there is still a chance that it will come back, but we really would be very much less optimistic. But yes, blood and ultrasound and history taking.
Thank you, Kate. Our next question, I was unable to do fertility preservation due to time sensitivities. Is there any funding programs to help fertility post-chemo if I am unable to conceive naturally post-treatment?
We might take that one then also. So I think we probably forgot to mention that some patients with lymphoma have very big disease in their chest going up to their neck, and the anaesthetists say it's too dangerous. And that is an unfortunate problem. That means you can't freeze the eggs or tissue. You can have Zoladex during your chemotherapy. And then if we do that assessment afterwards and there is some restoration of function, that's when we can do the fertility preservation. Now, we usually won't get as big a result, but, compared to not getting anything, as long as there is some ovarian function, yes, we're absolutely doing it. And it is still available for patients in the public, with Medicare rebates and in the public service.
It very much, I suppose, funding programs, it would depend on where you are, which state you're in. If there are low cost models, if it is public fertility, or if it is kind of your only option would be the private fertility route. But it would very much be dependent on where you are.
Thank you, guys. Our next question. I luckily had the time to freeze my eggs before starting chemo. I should finish chemo in January. Me and my partner originally wanted to try for kids next year. Is there a benefit to using my frozen non-chemo eggs versus trying naturally? And how long should I ideally wait before trying for kids?
Jenny, do you want to answer that?
So yeah, that's a really great question, and I think it's one that we get asked quite a bit by our patients. So the first part is about trying to conceive after having lymphoma, and I guess one of the main things is that you've recovered from your lymphoma, that the medical team are happy that it's a good time to plan a pregnancy. So, we usually communicate within the whole multidisciplinary team with the oncologists and whoever else is involved in your care to make sure that it's a really safe time and that there's no, that the medical investigations have been done to to provide reassurance that pregnancy is a good idea at that point. The next part of the question is how to try. So you've got some eggs frozen, and it depends also on the age that you are. But in general, we don't preclude, trying naturally as an option, because even though you've had lymphoma and the treatment for it, as we said in the presentations, the data on women who conceive after cancer, the outcomes for the children born are really reassuring, not showing any excess in numbers of genetic conditions or congenital abnormalities, or even a significant increase in miscarriage, etc. So when you've got that clearance from a medical perspective, it's been long enough since completion of your treatment, trying naturally initially is usually quite encouraged. And the other part of that discussion is that you might wish to use those eggs for a family building exercise, and looking beyond just having a baby to maybe having a few children, and potentially those eggs might be even more useful because of the difference between the age that you are or will be when trying, let's say, for a second child, and the age of those eggs, which are frozen in time. So there's lots to discuss there with your specialists.
Thank you, Genia. We have time for 2 more questions. We have two left here. So the next question, for the hormone replacement therapies, what type are considered safe for all of us, safe for us after the lymphoma treatment, and what are more risky?
So that's a really good question. And hormone replacement therapy needs have to be really carefully evaluated and individualized. In patients with lymphoma, there is no increased risk of hormone replacement therapy causing breast cancer or other cancers. However, patients who have had chest radiation are at a slightly higher risk of thyroid cancers and breast cancers anyway. And there's some studies going on at the moment looking at this, but there's no evidence that HRT increases that risk. Transdermal or patches are, on the whole, the safest form of hormone replacement therapy because it doesn't go through the liver. But there are patients who have very high risks of clots. They might have a congenital or an acquired clotting disorder, and hormone replacement therapy does increase your risk of clots a little bit. Again, the patches are safer than oral medications, and it becomes an individual risk assessment situation. But for most patients who have premature ovarian insufficiency, hormone replacement is strongly recommended for the reasons I mentioned before, particularly symptom control and bone health and overall health. And for patients who have had chest radiation, there is regular mammographic x-rays, etc., to check the breasts. And we believe HRT on the whole is very much better than no HRT, and the transdermal or patch ones are better.
Thank you, Kate. And then our final question for today is, I'm curious how the age of 24 years and 11 months for the NOx service was decided upon, and whether that might be extended in the future. This individual has also commented that they've had 2 beautiful children through donor egg pregnancy. So congratulations to them as well.
Wow.
You, Ashley?
Yeah, I suppose I can take that one. Well, first, congratulations. That's amazing to hear. I suppose with our 2 programs, so with our NOx program, our national program, which is funded by the Sony Foundation, and then our new program, our In Time program, which is our Paediatric and Adolescents. The Paediatric and Adolescents would have funding for up to 24 and 11 years, and then our NOx program then would have funding between 13 and 30. So both programs overlap within age range and pending diagnosis. But I suppose where the 24 and 11 months came from was just from our data collection from our NOx program to identify the gaps in kind of the age of the referrals that we were getting through, and the significant gap there within kind of supportive funding from that 0 to 13 age. So both programs do complement each other and fill those gaps. So now the national funding, depending on diagnosis and program, there would be funding for transportation, freezing and storage from 0 to 30.
Can I just add to that, please, Ashley?
Mm-hmm.
It's important to understand that we do ovarian tissue transport and freezing for patients outside those age ranges as well.
Mm-hmm.
But it's not, we just don't have the funding for the transport. So if patients are 32, if a patient is 32 and in Northern Territory, then we can still receive that tissue, but the patient or the hospital or someone else will have to fund the transport. We don't actually charge for the processing of the tissue. But to get back to that question about the patient who is 43, we would not do it in women over 37. And that's not for any funding reason. That's because of a lack of benefit. But we can provide, and we also do this for patients who have severe autoimmune conditions and other serious medical conditions. So it is available. It's just the funding for the transport.
Thank you, guys. And that's all for our questions. And thank you, everyone, for attending the webinar this afternoon. We'll finish up here, and we really do appreciate everyone's time, and we hope you've all been able to increase your knowledge on how to navigate fertility and changes during and after treatment. And thank you once again to Genia, Kate, and Aisling for being with us today and sharing your expertise. So we do understand this is a lot of information to take in, and if you have any questions or concerns regarding the content that's been covered today, or you would like more information or support, please reach out to us. You can email our nurse@lymphoma.org.au, and you're welcome to call us on our nurse support line. That number is 1800 953 081. We would love to see you all again in our upcoming online or in-person support groups or our future webinar or events. So keep an eye on the emails and our events calendar for future dates. And thank you, everyone.
Thank you so much.
Thank you.
Bye-bye.